heart and lungs, and there can be a delay in initiation of radiation therapy. This is a nice example. Typically, United States, a patient with a high-risk breast cancer underwent a mastectomy with immediate breast reconstruction, and immediately, together with a so-called risk-reducing mastectomy contralaterally with an implant. Now, this is technically spoken impossible to treat properly if this patient needs local regional radiation therapy. And the valve of, for example, a tissue expander should be put as such that it is not too close to the skin, because if it is, it can increase the risk of skin toxicity. But luckily enough, we know better how to shape our dose distributions. Instead of the old-fashioned square or rectangular field-based radiation therapy, we now have volume-based radiation therapy that we can nicely shape with our modern techniques. This is, in the meantime, published. A patient who had a Hodgkin lymphoma and had radiation-induced breast cancer, high risk, 7 nodes in the axilla involved, and then immediate breast reconstruction, and she was treated with postmastectomy radiation therapy using multiple electron fields. But look how nice the dose distribution covered the real target volume. There is no target volume here unless there is invasion of the deep space, draining via the deep lymphatic plexus. Especially in the sagittal view, it gives you a very nice overview of what can be obtained. And don't be surprised, this was in 2010. So nowadays we can even do much better with volumetric IMRT. Okay, this is the 25% isodose line, the blue. It's acceptable. If you go further to the 10%, you see that a large part of the body receives a low dose. But it is quite a nice homogeneous dose distribution to the real target volume. So this was 2020. And when we come to techniques, I always say it is about the objective, not about the technique. Nearly 20 years ago, a colleague from Switzerland said to me, "We're gonna buy a cyber knife." He said, "Congratulations, what will you do with it?" "Oh, we don't know yet. We have to still to think." This is the other way around. This is not how to do it. First, you have to define your needs, then the solutions to meet the objectives, and then you need to invest in the tools, and not the other way around, because, for example, it is well reimbursed. Target volumes, the definition of contouring and prioritizing is of tremendous importance. It's much more important than the tools that you have, than the techniques. This is contouring in the preparatory work of the ESTRO guidelines that you, without any doubt, know. These are radiation oncologists, CTV, non-involved radiation oncologists. So those were not initially involved in the project, so my contour is not in here. So there is quite some variation. However, the variation was less than we expected. So the project that we started was because there is a lack of evidence and even ignorance between concerning the interactions between radiation therapy and breast reconstruction. Not only in the radiation oncology field, also in the breast surgery field. And we hear a lot of scaremongering statements that are more gut-based than brain-based. So because of this, we formed an international core consensus group involving all professions, so also surgeons, pathologists, and imaging specialists, to prove that breast reconstruction and radiation therapy can be happily combined. And the components of the project, which is a PhD from Dr. Kaidar Person in Tel Aviv, Israel, a review about residual breast tissue after mastectomy, the spatial distribution of local recurrences after mastectomy. A component is review already published, but we are working on several data sets to go more into detail. The types of breast reconstruction, which is underway for publication. Target volume guidelines after implant-based, target volume guidelines after autologous, and then treatment planning once you have contoured according to the guidelines. And then some varia, for example, DCIS, or the use of bolus in the case of chest wall irradiation in post-mastectomy irradiation therapy, and a lot of commentaries. And I will go through this project step by step. And to help you, yesterday we did not have a case in immediate breast reconstruction because of the requirements. We discussed this on beforehand, but we have a case also for the contouring exercise that we did jointly together yesterday. So how far are we? So residual glandular breast tissue after mastectomy, published Annals of Surgical Oncology 2020. And what you can see is that depending on the type of surgery, nipple sparing and skin sparing, that the presence of residual glandular tissue varies. In the upper outer quadrant after nipple, depending on the publication, it varies between 10 and 100%. In skin sparing, 45. If you go in nipple sparing to the nipple areolar complex, in 65 to 90% of the patient, there is residual breast tissue after the mastectomy. And this defines, together with the draining lymphatics, the risk for having subsequent cancers. There are two groups of patients. One group is a patient who has cancer, so then you can have a risk of a new cancer in the residual breast tissue. And secondary, you can have the draining lymphatics that contain cancer cells in those patients. In the patients that have a risk reducing, also called prophylactic mastectomy, in those cases, they of course cannot have already cancer cells in the draining lymphatics, but they have residual glandular breast tissue in which they can develop breast cancer. So nice examples. Here, for example, on the MRI, you see residual breast tissue in here as well. So of importance is that this depends on the surgical technique. And we discussed this with the surgeons, they're co-authors, by the way. It is impossible to get it completely out because in that case, you would encounter problems with the viability of the skin flap. You need to have skin to cover the prosthesis, and this is impossible combined with removing all glandular tissue. Then how is the location of local recurrences distributed? Breast Cancer Research and Treatment, also 2020. Most is in the subcutaneous space where the draining lymphatics are. So that's where you see them. You don't see them in, for example, a homologous reconstruction in the flap. They're not directly in the flap. Sometimes they're deeply located in the neighborhood of the pectoral space, which can be draining by the deep lymphatic plexus, but by foremost are in the subcutaneous space. Some examples: subcutaneous space, subcutaneous space, subcutaneous space. This is more deeply located. It might also be a lymph node recurrence. It invades into the pectoral muscle. And here also it's deeply located after a TRAM reconstruction, so with an autologous reconstruction. The types of breast reconstruction, that's in progress, but we are very far there. We saw this week the second revision, and it is likely to be published in the coming weeks. And it's quite interesting to see what types of breast reconstruction are available. And it's not the objective to be exhaustive here. Here it is to show what is the interaction with radiation therapy following breast reconstruction. Target Volume Guidelines was the first publication, 2019, with a very broad international collaboration, as you can see, from all continents. And this shows us how we should contour in the case of immediate breast reconstruction using an implant. It should be decided not only on the type of surgery, but also on the risk and the expected site of recurrence. And for this, of course, we have to understand the pathology report and the surgical procedure. So what are the target volumes? As a base, they're identical to no reconstruction. But of course, you have the reconstruction, you have the implant, it can be an autologous one. You have all material in there, which is, of course, not part of your target volume. It comes from elsewhere. It does not contain cancer cells. And some tissue might be displaced. For example, if you put a prosthesis behind an implant behind the pectoral muscle is much more superficial than preoperatively. And are the target volumes similar depending on the type of reconstruction? Yes, but of course you have to take into account tissue displacement and stretching of tissue like the skin. This is one of the illustrations. You will see many of those illustrations and many more to come. It's designed all by a son of my PhD student. This is the lymphatic drainage pattern. So the breast drains primarily via the axillary lymph nodes, level 1, level 3, level 4, the internal mammary lymph nodes. The internal mammary lymph node involvement depends on the extent of axillary nodal involvement and on the position of the primary tumor. Medially, higher risk, but especially if the tumor is deep-seated close to the pectoral muscle, because there is the deep lymphatic plexus, and the deep lymphatic plexus drains more to the internal mammary nodes as well as to the axillary nodes. So it depends a lot on where the tumor was within the breast. So this is a theoretical drawing where the pectoral muscle covers completely the implant. And I know that many of us thought that this was always the case. This is impossible. First of all, the pectoral muscle is not big enough to cover the implant completely. And secondly, it gives poor quality of life. It gives side effects. So if you participate to the surgery, you can see that part of the muscles are detached from the ribs where they adhere. And in general, they cover about half to 2/3 of the implant. And then the surgeon puts something like a mesh to prevent that the prosthesis is completely subcutaneous, because that leads to complications. What we see nowadays more and more, unfortunately, I would nearly say, is that the implant is positioned before the pectoral muscle, and that it is only skin and a mesh or other supportive material that covers the implant. This is contouring by us, the writers of the guidelines. This is the contouring you've seen before. This is the contouring done by two of the participating surgeons. And these are the consensus guidelines. So if there is no indication to treat the deep lymphatic plexus, this is the case in 90% of the patients. All the patients that have radiotherapy to the chest wall because of nodal involvement, not because of the local tumor that was very big. Most of our patients have a reason for chest wall irradiation based on nodal involvement, not a local tumor. Then it's the draining subcutaneous plexus. In yellow is the pectoral muscle, in green is the implant. So here is the pectoral muscle, the minor and the major, covering about half of the implant, and this is the target volume. Then you have patients in which the primary tumor was deeply seated or other high risk factors for having involvement via the deep lymphatic plexus. And in that case, you have to contour also this one. And of course, in this case, it will be very difficult to spare the prosthesis. The implant itself is not the issue. The implant is, and I show you images later, is of course the tissue surrounding the implant where capsular contraction originates from. So here another drawing, it's a prepectoral one, a prepectoral, subcutaneous, and then the deep lymphatic plexus. Consensus guideline for after autologous is work scheduled. Treatment planning after implant-based is published this year. It's very recent, online already. And what you can see is independent of the technique, field-in-field, hybrid, IMRT, VMAT, tomotherapy, you can obtain sufficient coverage of the CTV chest wall and of the internal memory lymph nodes, and to some extent also sufficient sparing of normal tissues. The lines here below is the heart, and the line here are the lungs. So you see that, for example, in field, one did worse for the contralateral breast, but in general it's okay. And it depends a lot on experience and the protocol that you use in your department. But our message is field can handle many patients, most of the patients. For some patients with challenging anatomies, you need another type of technical approach. Treatment planning after autologous is work in progress, but imagine it will be if you have a deep reconstruction, a DIEP reconstruction with skin. That skin is not part of the target volume. That deep reconstruction is not part of the target volume. So you can get very weird clinical target volumes and thereby adaptive radiation therapy. VARIA, we have a lot of comments and papers and discussions, and they get high. They get in Lancet Oncology, for example. This is a comment. Should we worry about residual disease after mastectomy? Yes, we should. We have a lot of experience in patients who were not ideal candidates for mastectomy with immediate breast reconstruction, who were omitted radiation therapy, and who had awful recurrences 1-2 years after finishing adjuvant chemotherapy. What are the guidelines for immediate breast reconstruction? This, in the meantime, is out there. The issue is that there are many guidelines and they are often in conflict. So we made an overview of those guidelines. And a lot more is in progress. Just use PubMed on the name of Kaidar person and myself, and you can follow us. Concluding, so we need to validate this, of course, because when we started, I estimated more than 95% of all the patients worldwide were just treated like the intact breast, like the implant or the reconstruction or whatever was just part of the target volume. Now people start realizing that this might contribute to the sometimes disappointing cosmetic outcome after radiation therapy following breast reconstruction. So if we can lower the dose to the surrounding normal tissue by, let us say, 50%, that the implant and the surrounding non-target tissue receives between 30 and 70%, it might very well be that we have much less capsular retraction. This trial is one of the validation trials, and you're invited to participate. This trial has two parts. The one, but this is difficult, is a randomized trial. Patients who are eligible for mastectomy, radiation therapy, and reconstruction are randomized between skin-sparing mastectomy with immediate reconstruction and total mastectomy. Then they receive radiation therapy, and after 1 year, They have, in the case of immediate breast reconstruction, finalization, and in the other case, they have the breast reconstruction after a year. And the target volume contouring is according to the guidelines. And the other one, the prospective cohort, if you cannot participate to the randomized part, is just registering the patients who have this, treat according to the ESTRO guidelines, and follow the patients according to the protocol. And we need to do this together. I operated a lot of breast cancer patients to see what the surgeon actually is doing, because otherwise it's very difficult to imagine what happens. So the target volume for post-mastectomy radiation therapy depends on many factors, including type of mastectomy reconstruction. The planning of whatever intervention has to be done together, multidisciplinary. We need to work together closely with surgeons in this field, and we need to participate to prospective research. These people I would like to thank very much. And in red are surgeons, pathologists, etc. And thank you very much.
Okay.
Thank you, Professor Orikia, for this, as usual, nice and comprehensive presentation about post-mastectomy irradiation. I'm bewildered about something. Long time ago, we used to irradiate post-mastectomy immediately after surgery, after healing of wound, then chemotherapy. Now, after the era of chemotherapy, we are delaying irradiation, post-mastectomy, or even breast conservative surgery till after chemotherapy. Do you think it's justified to delay irradiation?
If we look at the data from the past, from the 20th century, we had reason to be worried. And that's why most of the protocols advise to start radiation therapy within, let's say, 5 weeks following the surgery or the adjuvant chemotherapy. I still think we need to maintain this, but not because of oncological reasons, but because of psychological reasons and the point of organization. If your organization is not capable to start the patient within 5 weeks, you have an organizational problem. We published, I think it's 2 or 3 years ago, a population-based study in the Netherlands, where we demonstrated that it does not matter at all for patients treated more recently. So even up to 6 months, there was no decrease in the outcomes, no worse outcomes at all for treatment after breast conserving therapy, independent of whether the patients received chemotherapy, endocrine therapy, or whatever. It was even so, and we cannot explain it, that the patients who started very soon after the surgery had a worse outcome. So that we cannot explain. I would say make your organization as such that you can start swiftly. It's best for everybody. But if there is something that makes you postponing the treatment, reassure the patient and yourself that this is not a main problem in contemporary treatment times.
Thank you very much. Any questions? Now I'm honored. Thank you, Professor Orikia, and we'll meet again after this lecture. Now I am honored to present one of my dear friends, one of the experts in the field of radiation therapy, one of the eminent professors from Ain Shams University, Professor Muhammad Sabri. He will be talking about the pattern of local recurrence post-irradiation, Ain Shams breast cancer. Roberto, sorry. Sorry, I'm sorry.
No problem.
I'm honored to reintroduce my friend and one of the most eminent professor in the field, international figure, Professor Roberto Riccia from Milan University, will be talking about variability in target volumes and organ at risk, contouring in breast cancer radiation treatment. Sorry, and thank you for accepting our invitation.
Thank you very much. It's really a pleasure. Do you hear me? Okay. Do you see the slide? So we can start just with.
They are. Yes, you can share your slides, please.
Yeah. Okay. Eva.
We are hearing you.
Ho fatto casino.
Stanno andando?
Non lo so. Non ho capito. Share screen.
Vada qua sopra, doveva venire quella cosa di ieri. No, aspetta, clicchi qua ancora un attimo. Aspetta, ecco.
Qui, questa qua?
No,
Sì, questa.
Dietro di uno. Ok. Ora dovrebbero vedere.